All right, let me get the camera. Oh, it is on you. Look at that.
Yeah.
Go ahead, sir.
I've been amused as well as amazed at the confusion and misconception that surrounds these questions. What is behavioral optometry? What is a behavioral optometrist? What is the behavioral concept of vision? It might even be easier to discuss what it is, not rather what it is not. It is absolutely essential to know and understand that the term behavioral refers to a concept and model of vision, and the optometric application of this concept to all optometric clinical activities. That was Bob Kreskin in 1993 at Monte Carlo, talking about behavioral optometry as if it was in question. He went on to say that it was Harmon who stated that the place played by posture and movement in visual processes cannot be ignored in constructing a satisfactory conceptual model of vision. The mechanisms for posture and movement are just as much a part of visual systems as are ocular and ocular-related structures. I hear all the time about developmental optometry taking the place of behavioral optometry. And I think that's something that should not be done. And this is what this lecture is about. My beginning in behavioral optometry started at the Neverly Country Club, Eastern States Congress. And I remember walking in, it must have been 1977. And I walk in, and who's on the stage but Armand Bastien with his son Yves on all four doing the bear walk. And I'm saying, where's optometry? That's behavioral optometry. And I remember in 1985, Mickey Weinstein asked me to go and walk with him for a minute, and he put his arm around me, and he said that COVD wants to join OEP and make one organization. What do you think? And I said, I don't like it. And he looked at me, he goes, I don't either. Not working. Just forward?
Yeah, you've been flying for. There you go.
So I believe that this was the birth of developmental optometry when Tony Bristol wrote in Visions about how it was too hard to explain behavioral optometry and that we should change it to developmental optometry. And I think that this was the death knell to behavioral optometry. Here, Al Sutton is talking about tonicity, that a plus lens relaxes tonicity and a minus lens increases tonicity. Talking about a behavioral effect. So I want to do something with you for a minute. I want everyone to sit as if they're in a meditative posture, feet on the ground, hands on your lap, eyes closed. And I want you to think about your body realigning itself, not trying to do anything. Just that someone just moved their head. Just allow your body to readjust itself and align itself so that you're aware of your body in its best position. Because when you do that, you're righting yourself so that everything that flows is going to be flowing more easily. What I've started to do with myself is I started to use imagery to feel my body in this state. And I would do like a body scan where I would start from the top of my head and scan my body down from the back, down my legs, and then back up the front of my body, sensing aspects of my body that needs to be affected by my imagery. And lo and behold, when I would have a kink or something in my body and I would start doing this, and I would start manipulating that area using my visualization, I could fix my body with imagery. In our breakout room, somebody was talking about the idea that we are going to eventually go beyond ourselves, outside of our bodies, in a sense, being ourselves outside of our body. I think eventually we can fly, and I think we can do it through imagery. And I think that imagery is going to be a new science where we can heal ourselves and extend beyond our bodies using imagery. So I want you to feel or think about rolling your shoulders. Just think about it. And then I want you to very gently begin to roll your shoulders and then roll your shoulders. That first thought of I want to roll my shoulders, how many saw your shoulder? How many visualize that area of your body that you can sense it? That's response. Action is the beginning of that action, and the behavior is what Mickey Meinstein calls organized behavior. But there's something that's coming before that. Where does that sense come? That arousal that allows us to now think about our body to respond. And I think that's where we need to go. Al Sutton says that the response to light is altered by a lens to affect posture, meaning, and action. So when I think of that, I think of imagery, and I think of Mr. Miyagi in Karate Kid. And I think of the time when he's working on the bonsai plants. And he's fixing the bonsai plants, and the boy walks in and he goes, what are you doing? I'm doing the bonsai plant. I can never do that. Mr. Miyagi says to the boy, I've got his name, he goes, close your eyes, make a picture, open your eyes, make the picture, visualize. So what's the 4 circles? I had a patient come into me. He was he would work for large corporations and teach programs to large corporations. And what he came to me for specifically was, I want to be, if I'm going to present it to a board is a very large organization, and there's a lot of people that are at the board. And when I'm presenting, I want to be able to see all of the people while I'm presenting. That's centering. I'm looking at one person, but I'm centering on the whole board. Identification. Phil Kruger did a study where we looked into an optometer, which measured accommodative response, and we identified numbers. And he measured the accommodative response. Came back the next day, same people, same time, and we added up the numbers. What was the difference in the accommodative response? The accommodative response was greater when you added the numbers. What about when you put your own feelings towards this activity? Meaning this. I heard a presentation once that there's 3 levels to hearing. I can hear the sound. I understand the meaning of the sound. And then I put my own interpretation to that meaning of the sound. Does that also increase the accommodative demand? Anti-gravity, I think, is tremendously affected by yoke prisms. I don't know how many people are using yoke prisms. In my practice, we use it extensively. And we're going to talk about that in a minute. Speech and language. My understanding of the relationship between vision and speech and language is this. how does an infant begin to understand their environment? Everything goes into their mouth. Everything is mouth. Contour, texture, size, whatever it might be. The second stage is hand, haptic, connecting with what was found in the mouth. So does the mouth now match what the hand feels? And then that is projected out into space through vision. Once we project it out in space through vision, we identify. And that's speech and language. The reason why I'm going over these 3 circles is because Tony Bristol says it's too hard to explain behavioral optometry. How many times have you presented this to your patients? That this is behavioral optometry. And these are the qualities that behavioral optometry affects. I think that when Bob talked about the 3 levels of experiencing space, I think that's a replication of the four circles without speech and language, which we just add identification to it. I walk into a room, where am I in relationship to the objects in the room? Where am I in relationship to the object that I'm related to? And then what is it? And he says a lens can do nothing to a person can do much to a lens. I was once here, wasn't at this hotel, but it was one of the other hotels, and somebody said, I want to introduce you to somebody. And who are you going to introduce me to? Emil Franke. So meeting Emil Franke was like meeting Mickey Mantle, to me. That's what it was like. And I walked up to him, we introduced whatever, and you know what I said to him? I said, give me something. It's exactly what I said, give me something. And this is what he gave me. Make believe that you have a string that's attached to the furthest point in space that we can assess. What's the furthest point in space that we can assess? The basin at distance, I think recovery. What is the closest point in space that we can assess? It's the base out at near recovery. And he says, think of that string attaching the base in at distance and the base out at near, and then think of tugging on that string because you're accommodating to the convergence insufficiency. What factor, what function is reduced first? The basin at distance, the recovery at the basin at distance. And what Emil was saying was that a reduced basin at distance is pathognomonic of what, I don't know if he named it or I named it, an adapted convergence insufficiency. I took that further. And I think that from that, if we can have an adapted convergence insufficiency, then maybe all of the diagnoses that we have are actually ramifications of adapted convergence insufficiency. How does that work? Well, if I'm pulling in, I'm going to get a spasm, eventually an insufficiency in the accommodative system, and I'm going to get a divergence insufficiency if I continue further. If I go further than that, pulling in even more, I can get a convergence excess. I believe that all of these diagnoses have an underlying convergence insufficiency, and that convergence insufficiency is the granddaddy of all diagnoses of the binocular system. I'm not talking about strabismus, I'm not talking about amblyopia, I'm not talking about development delay, I'm not talking any of these. Basic binocular dysfunction, I believe, is coming from a CI. And how you adapt for that CI is based on your own nomenclature within yourself. Al Sutton once referred a patient to me. Al was my mentor, along with Nat Flax. Nat Flax was my structural mentor, and Al Sutton was my spiritual mentor within optometry. And so one day Al referred a patient to me, and At that point, I was just beginning to work with yoke prisms, and I prescribed yoke prisms, and I got a very good effect, and I spoke to Al. I called him up and said, Al, this is what I did. The only time he ever got upset at me, Joe, why didn't you do body work? Why didn't you do body work? I can't do body work. That's not me. That's not who I am. The optometrists, the first generation of this, they were like the OTs. They were OTs and optometrists together. I couldn't do that. So I said to Emil, I said, I was upset because I upset Al. And Emil's response to me was, prescribing is like playing music. It depends on what music you want to play. That was his response to me. So here I have the value of a lens is found that it changes orders to a system. What does it mean, changing orders to a system? I had a hard time understanding that, changing orders to a system. And then I heard about, the Sully Sullenberger, flying into the Hudson River. And if you saw the movie, his co-pilot said it was during the trial that he had, that he said that he didn't adhere to all of the points that he had to adhere to. He said if he did all of the things that he had to do, they would have crashed. He changed orders to the system. When we prescribe anything, whether it's therapy or lenses, we are changing how this whole system works. And it's not just visual. It goes back to the whole postural and the functional part of us. I met Streff once at a meeting here, and I said to Streff, I'm using quarters now, and he said, no, eighths. You got to use eighths. And he has you do to the desired symmetry. What's symmetry? How often do we think of symmetry in prescribing, in therapy, in results of therapy? To me, symmetry is moving from one point in space to another point in space with ease. The ease with which you maneuver the movement of your eyes creates efficiency in its function. The greater the symmetry. Our responsibility is to create that symmetry. And symmetry isn't like you have symmetry, you don't have symmetry. Symmetry is a variable thing. How much symmetry can you develop? And the more symmetry I think that you can develop, the more ease within the visual system you have. With due diligence and respect. So symmetry is a flow, a movement from one point to another. The ease with which you maneuver the movements are responsible to affect that with due diligence. I don't know if you've read this article, but I read this article a number of times a year. And it's about, retinoscopy. I have a practice, I run a vision center, and in the vision center, we have ophthalmology as well as other optometrists that are outside of my aspect of the center. I run the vision therapy part of it. And everybody uses an AR, automatic refractor. How can you use an automatic refractor to understand what it is that you're seeing? It takes me how many times going back and forth to get the right symmetry of that pupil. And he talked about cognitive retinoscopy in this article. I never heard the term before, cognitive retinoscopy. Color brightness, and the center and the periphery have to be uniform. And if the center and periphery aren't uniform, you're not getting the prescription that's really being appropriately presented to you. Using a streak is almost like using an AR to me. I ask, I'll ask my students, what do you look for in retinoscopy? What's the first thing they say? Movement. That's the first thing they say. They didn't even know to look at what the other aspects are. The last thing that we look at is movement. I use gyroscopes on every patient. I do them in my workup, and I do them on every reevaluation. Every reevaluation, we do a keystone skills and we do a gyroscope. Amazed at the difference that you can see with the gyroscope. I call it cortical binocularity as far as gyroscope goes. So this was, all of it, this was done at SUNY. This was with my interns. And I decided that we're just gonna apply a lens at the workup and see what we get. So this is just from plus 52 base up at the same sitting. This was plano. This is a quarter, the same sitting. Same sitting. Same thing with the whole, capsule. This is plano, and this is with a half, and I think 2 base up. Again here, this is with plano, and that's with a half and 2 base up. So you get changes in visual motor, you get changes in organization, you get changes in ocular motor. Let's talk about vertical yoke prisms. So going back to my slide where I've talked about convergence insufficiency, I think that 99% of my children have convergence insufficiency, even if they're showing overconvergence. There is a convergence excess concept that I don't think applies, and I don't see it that often. But one way that you can tell a convergence excess that's a true convergence excess as opposed to an adapted CI is looking at the base outduction at near. And the difference would be that a convergence excess who's a true convergence excess, you'll have a high break and a high recovery. An adapted convergence insufficiency that's showing up as a convergence excess will show a high break and a low recovery. So if you get a 30 break and a 2 recovery, to me, that's an adapted CI, even though they're showing ESO. So most of my kids are going to get base up prism. Base up prism creates down gaze. Down gaze promotes convergence. But that's only stage 1. Stage 2 is that if I create convergence by creating down gaze and I'm enhancing convergence, then I'm enhancing my ability to lock onto a target in space. If I enhance my attachment to a target in space, I'm enhancing my sense of where that object is in space. I'm becoming more aware of my body in space. That's proprioceptive. That's the second level. The third level of yoke prism, base up, is the center of gravity, which is around the navel area, moves opposite to the eye movement. So if I prescribe base up prism and I'm getting an effect vestibular, it's almost like I'm riding my body, I'm going on my heels. So a yoke prism, almost like the 4 circles. I'm affecting ocular motor, I'm affecting proprioception, and I'm affecting vestibular. Bob says that you prescribe prism, but the base is academic, the amount is clinical. I believe that we're creating, a change in spatial awareness through orientation of our bodies in space. I don't know how often you guys experience critical empathy, but we experience it a lot in our practice. Maybe once every week or so, there'll be a child that's going to go through something. We're creating change within this person. And how well this person adapts to that change is going to let us know, how well this child is doing in therapy. Going through explaining to the parent, explaining to the child in the way that the child can understand what it is that they're going through allows them to go through this process more easily. And once they go through the process, you know, McDonald would say that it's going to be a very positive effect. And he says when optometrists are attempting to develop modifications of visual behavior, they become aware that what appears to be minor modifications of visual habits may have deeper underlying effects. We're seeking that out. We need to seek that out. Al talked about every finding that we have and every prescription that we make has a present, past, and future. So we all know that if we have a patient that we've been taking care of and no prescription goes out into the world and comes back, and all of a sudden they're showing -1/4, -50, whatever it might be, you understand that they are going through a process now of some kind of accommodative excess, stressful experience in their life, and you can anticipate what it's going to be like in the future. So of course, you're not going to prescribe the minus. In my practice, we have, it's in Williamsburg, Brooklyn, and the essence of the community is Satmar, which is a very strict Jewish, community. And I've never seen what I've seen in this population before, which is significant accommodative excess to the point where they can have acuities down to 20/100. There's no prescription. And they have significantly reduced acuities. I've never seen it in any other, community that I've practiced. So if anyone has any thoughts about that, I'd be happy to look at that. I've started to give magnesium, and I started to do acupuncture for them as well, and I don't know the effects of that yet. So this is a presentation to, I guess, speak to the idea that what we call ourselves is very important. And I think that, Bubba and I were talking about this before, and I'm sure Bubba will have something to say about it. I'd be happy to hear that. That development is a concept. I don't believe that. I think development is a function. I think behavior is a concept. That's what Bob said, the concept. And, as behavioral optometrists, to call ourselves developmental is moving away from, I think, how this all started, which is those 4 circles. And those 4 circles are, says everything, and I think it's up to, and how do we explain that? Just the way we talked about it here now, like explain to a patient, this is what it means. And, it's putting all of the pieces together, and development does play a role, but development at each stage of the behavioral process is what has to be looked. Thank you.
Okay, wait. Oh. That was close. That was not. That was. Don't leave yet. Don't leave yet. Embedded in here, there probably is. Are you leaving us with some specific questions or a question? You have, okay, Jeffrey has them. Okay, thank you. This is yours.
Point of clarification.
Yeah, got a question coming. Give. Yeah.
To the McDonald's.
And I gotta put you back on
There.
and don't run yet.
Okay.
Oh. Yeah.
Glenn, you have a question?
It wasn't a question. He wanted a picture of the slide.
Okay.
I have a comment about the young people you're seeing in the Satmar community. I'm practicing in Montreal. We have a huge Hasidic community there as well. Up until a couple of years ago, that was the only place I was seeing this high myopias and putting a lot of plus on kids early, where I've got families where the older kids are -10, -14. I have a father -18. And if I can get +50 on these kids when they're 5 years old, sometimes their endpoint is at -3. It's a huge difference, just being able to modify their behavior and having them work on a slanted desk instead of a regular desk where their nose is on the paper. Up until recently, up until the last few years, I was only seeing this in these communities. Now I'm seeing these same problems in kids in the regular community, if you will, who are spending hours on computers and tablets and cell phones.
So I haven't seen that in my secular communities. And my practices were in secular communities up until about 8 years ago. And so for 40 years, I saw these patients, and it was dovetailing into the time where they were on computers more. I'm not seeing it, that much, at all. I'm seeing it as I had seen it earlier. But the Satmar community is so intense, not just in their learning, but intense in their community, way of life, that everything is just structured so intensely. And the boys, obviously more than the girls, because of the demands on the boys to learn, and not the girls.
They start younger and they read more hours. They often go back after dinner and read some more.
So I think it's actually more the community, but I think it's both. But the community is so structured, and part of what I do with them is to get them to be to be more aware of how they can unstructure somewhat and still stay within the community. So it's not just the prescribing. Samantha.
I'm also in the New York metropolitan area, and some of the patients are traveling up to see me as well from the very religious Hasidic community, and from the Satmars in particular, that they are so rigid and also very limited. They're some of the kids who make their way all the way through school, they really don't have any secular awareness of their environment. Some of them don't even communicate in English and really do not learn that until into adulthood. They depend on the females to be able to communicate with others in the community, because they will need to go out and find things. They also tend to do, they've got microcosms where they are very self-sufficient. So there's another one up in Rockland that's an offshoot of the Satmars. That's Curious Joel. There's a whole community up there. So the reason I bring it up is because we talk about centering and over centering, and just they are self-excluding awareness to the environment as a way of life. And unless, some of them don't have the whatever it takes to really push forward in the yeshiva intellectually, however that goes, and they find other ways to earn a living out in the world, and some of that shifts. And I have one of those right now who's starting to question life and has talked to me about, in private therapy sessions, how limited his exposure has been, and like that he just has had no worldly knowledge until he got his hands on a cell phone and started to explore. But to your point, it's really a very overly centered community and excluding a lot of environment.
And they make no excuses about it.
No,
Know exactly what they're doing.
They're doing
And-
it intentionally also. They have different roles. Not everybody does everything. And that's part of their belief system. A man and a woman married makes a whole person. And so it's part of their belief system that not everybody does everything.
Yeah, what I think is also interesting is that they have no computers. There's no computer access. There's no nothing. So to your point, I'm saying, I understand, but I'm saying, like, in this community, without computers, their myopia is beyond any secular community that I've seen, and that's without computers or cell phones or anything. So, thank you.
Or-
Oh.